Okay, so let's talk about aneurysms. Okay, like I said, it's a localized weakening and dilation of the artery. And again, I'm drawing this up here. But you have this setup, but we have, and this looks like it's a long blood vessel, but a localized area of this blood vessel is dilated. Okay? And what happens is it's thinning over here. And again, I'm going to show you again. It's thick here, normal thick, and then it gets thin in here and thick again over here. Right? Like this. Okay? So because it's very thin here, when blood rushes in here, this is going to get bigger and bigger and bigger because it's so thin here, eventually it's going to burst. Okay? So that's why we call it a localized dilation and weakening. It's weakened here, which means it could burst. Okay? So it could be due to atherosclerosis, weakening of the area of the blood vessels, I showed you before. High blood pressure can cause this. It could be congenital, something you're just born with and not realize that you have this. Or even tertiary syphilis, which we'll talk about when we get to reproductive. But tertiary syphilis can also cause a certain type of aneurysm, which we'll talk about. All right? So with each heartbeat, the area balloons out more and more. And like I said, it can get so big that it will burst. Okay? So we have two different types. We have fusiform, which is what I'm showing over here. Kind of fusiform means football shape. So it kind of looks like a football, sort of thing, right? Football shape. Well, you can also have a saccular one, and a saccular one is, it looks like it's just ballooning, and I'll just show you a really fast picture of it. It's ballooning like that. Okay? So it's saccular. It's like a sac there. Okay? So a few that you should know. There's an abdominal aorta aneurysm, an AAA. Okay? This is the most common aneurysm due to atherosclerosis. This, of course, happens in the abdominal aorta, which is what we're concerned about. You don't want your aorta ever to burst. The amount of pressure in the aorta is the greatest throughout your whole body. So you will die immediately with something like that. So what we have is that this abdominal aortic aneurysm tends to develop emboli that embolize to arteries and intestines, legs, ischemia, infarction, and so forth. So again, like I said, the blood will stagnate in this area, right? I talked about that. It'll stagnate in this area. Go this way, and then stagnate. Move that way. Eventually, you're going to form a clot here. Right? That clot could embolize. And if it's in the abdominal aorta, and this is where you got to go back to A and P2, you need to know branches off the abdominal aorta. Okay? Obviously, it's going to go to your intestines. So you could actually throw an embolus from here into the intestines. Okay? Not the intestine itself, but the blood vessel to the intestines. Could go down into your iliac arteries, go down to your femoral arteries, and so forth. It'll actually cause an embolus that occurs in the legs. So they may develop emboli, okay? You could also, if this is big enough, and I have felt them, you could actually put your hand over the abdomen in the middle where the aorta would be. Now keep in mind, the aorta is posterior to all your organs. But if you put your hand here, and if it's big enough, you could actually feel what we call a thrill. I know it's a weird name, but it's a thrill. And you'll feel a buzzing happening, like a pulsating buzzing happening on the palm of your hand. We call that a thrill. Zoop, zoop, zoop. So basically what's happening is that we could hear that, right? We talked about that, called a bruit, an abdominal bruit. We put a stethoscope and could hear it. But now, if it's so big, we could actually feel it. And we call that a thrill. Okay? So that's what that is. Okay? We also have something called a dissecting aneurysm, aortic aneurysm. most common in the thoracic aorta. So it's going to be up here, right, above the diaphragm, okay? And this is due to hypertension or, like I said, there was a special one that syphilis does, tertiary syphilis. It's the third stage of syphilis that happens many years, decades after the first contact with syphilis, whenever you have it, if you have it. Basically what it does, and I'll show you a picture of it, it's dissecting. So what happens is it enlarges by tunneling between the layers of the artery. So what we're doing is we're taking the artery and we're splitting it. Think of like a banana with a banana peel, and we're separating the banana with the banana peel. Maybe that's not so good of a, but that's what we're doing. Basically, it's the actual layers of the arterial wall are separated, that the blood is going in there, that it's separating. I'll show you what that looks like. And people who experience this don't usually survive, because it's when you start having this dissection happening in the arterial wall, abdominal arterial wall, not abdominal, the aortic abdominal, the aortic artery itself. When that happens, the amount of pressure over there dissects very fast, and they feel as though they feel this tearing sensation that's happening in their chest, and they fall right down to the ground. All right, they get this sudden onset of this tearing, ripping pain that's coming from the chest. They get tachycardia, pallor, basically may have different blood pressures in the arms depending on how that is, right? So if you have your heart here and you got your, right? So this is your aorta, your aortic arch. Right? So just a little review. Your aortic arch, this is going to be your brachiocephalic artery. This is going to be your right subclavian artery. This is going to be your right common carotid artery. This is going to be your left common carotid artery. And this is going to be your left subclavian artery. The subclavian goes down to your arm, right? So your left subclavian goes down to your arm. So if we have a dissection that is going to occur, let's say, someplace here, then the blood pressure, that means the blood pressure should be fine at this level here because it's happening proximal to the site. Does that make sense? Blood is going to go this way. Blood pressure should be fine on that side. But the blood pressure this way is diminished. Does that make sense? Right? You're going to have a stronger blood pressure here, but a weaker one over here. Now, don't get me wrong. The occurrence can happen here and then both the same. But that's why sometimes the blood pressure in the arms may be different depending on the branch off the aortic arch, okay, and where it hits. Well, like I said, this is usually fatal because it happens right there. God forbid something happens right now. By the time the paramedics come, 10 minutes, the person's already dead. And even if the paramedics come, you've got to get them to the hospital for them to do any kind of surgery. Then you've got another half an hour. So this is usually very fatal. I don't know if you know the TV show Three's Company. The guy's name was John Ritter. John Ritter, Three's Company. He was also in, I forgot, there's something, 12 Things with My Daughter. This is back in, I think, the early 2000s, late 90s or whatever. He had another TV show. Anyway, John Ritter, R-I-T-T-E-R. He had a dissecting aortic aneurysm. I think it was at the studio, and he just died right then and there. Most people don't know that they have this as much as hypertension. So it just happens, and that's it. There's no screening that we can do on people like this. Okay? So it's usually very, leads to death most often. Okay? Now, Berry is a saccular one over here. But this Berry aneurysm It looks like a berry. That's why they call it berry aneurysm. Like a berry comes out of here, saccular. This happens in one of the one of the blood vessels in the brain. And like I said before, these aneurysms, people don't know they have them. So whenever you hear that someone very young, maybe in their 30s or whatever, 40s, 20s, most likely they had a berry aneurysm in the brain, like they just died of a stroke. It's so young, why would that happen? Because there was something wrong, genetically wrong with this blood vessel in the person's brain. But again, they don't have any symptoms of this. When this bursts, they die right then and there. Okay, so that's what happens. So it's one of the so it's basically a saccular aneurysm that occurs in one of the blood vessels. We call the remember the circle of Willis, right? The circle of Willis is the blood vessel unit that's happening inside the brain, and all the branches that come off this the circle of Willis, and that's what's happening there. So this is just showing you 3 different types, right? Here's the fusiform, which I kind of showed you up there, the fusiform aneurysm. Here's the sacculated or saccular aneurysm, kind of looks like a berry over here. And then dissecting one, you can see where it actually will, the layers of the blood vessel, the artery, starts separating. And that's what's happening over here. It becomes very thin here, and that will burst. We call that a dissecting aneurysm, and that's what the one that John Ritter had. Okay. Another showing you here again what a dissecting aneurysm is. I think it's a little bit better. You can appreciate it. If here's the thickness of the blood vessel over here, you can see that there's an opening, some sort of congenital deformity that you would never know about. Loosens up and it starts dissecting the layer of the artery, in this case the aorta. And that's where it starts rupturing and splitting up, and you can't really do much about that. Okay. This is a berry aneurysm, right, in the brain, part of the circle of Willis, one of the branches off of it, and you'll see a saccular area over there. Again, most people don't know they have these, okay? And that's what happens with that, okay? You can see the saccular area right there, right? The arrow, I thought this is where the arrow's pointing. It's not. It's pointing to this area here. And they can do an arteriogram, which is shooting a dye in the person's bloodstream, and they can see through fluorescence where the areas are, okay? All right. So the treatment for aneurysms is to remove them if you can. There's a few different ways you can do that. Okay, you remove the aneurysm and try to repair that arterial wall. We'll put in some sort of synthetic tubing in the place of it to replace that segment. Okay, so I'll just give you an example of how they do this or what this actually is. Here's the aneurysm. See the fusiform aneurysm that's happening here. Let's say this is the abdominal aorta, and it's coming out like this. So what they're going to do is they're going to put in a catheter again in here and then open up this synthetic tubing that the tubing will look like this. So now the blood goes through this tubing, so the pressure is not on the wall anymore of the original artery, but instead in the synthetic tubing so that the blood flow can go this way. And that's basically what they usually will do in a case like this. Okay? And this is what the tubing kind of looks like in place in situ, where you could actually see with the naked eyes. Okay? Again, shown in a cartoon format. There's the aneurysm, and then they put this synthetic graft or this tubing over here, so the pressure is not on where the blood vessel is itself. Okay. So let's talk about peripheral arterial disease, all right, PAD. Now this is a type of what we call peripheral vascular disease. But when you have PVD, we're talking about veins and arteries and arterioles and capillaries. It's a whole umbrella of everything, okay? So sometimes people refer to, well, you've got peripheral vascular disease when they're really referring to specifically the artery. So you might hear it interchangeably. But understand that what we're talking about here is the peripheral arterial diseases of the peripheral vascular diseases. I know it sounds a little crazy, but think of it as an umbrella. Anyway, peripheral arterial disease is atherosclerosis in the peripheral arteries of the body. All right, most common sites are going to be in the legs. All right, this leads to ischemia, infarction in the peripheral body structures. Okay. How the person is going to present is what we call intermittent claudication. Okay, this is kind of analogous to angina of the heart. Angina is chest pain of the heart because of less blood flow going to the heart muscle, and they experience chest pain. So it's the same way here, we're going to have less blood flow going to certain parts of the legs, and as they're walking, they're feeling, because they're exercising the legs, they feel pain in those areas. So we call it intermittent claudication. Intermittent because it resolves after rest. Right? So when you rest it, so it's intermittent. It's there when you're walking, it's gone when you're resting. And that's what's happening. So pain on exertion of leg muscles involved with the compromised arteries, wherever they're going. And like I said, pain usually will go away upon rest. All right? The best way to do the management on this is simply bed rest and just elevate the feet. Okay? When you do this, you're going to decrease the oxygen supply, or the oxygen demand to those muscles. Right? So if you're walking, more oxygen needs to go there. But if they're ischemic, you can't get all that oxygen there. So we're just going to raise those legs and just rest, so that the leg muscles don't need all that blood supply. All right. So the 6 P's of peripheral arterial diseases. Pain. People will have pain when they start walking. Okay. Pallor. The pale color to the area when elevated. When it's elevated, there's going to be pale color. All right. So while they're lying, because there's less blood flow going there, the legs itself is going to be very pale. Okay. Pulselessness. In other words, when you feel the pulse, the dorsal pediis pulse or the popliteal pulse, which is behind the knee, the femoral pulse, depends on where the atheroscleroma is, or atheroma is, but you're going to feel less pulses. And you would compare them on both legs, right? You feel the dorsalis pedis on both feet. One I don't feel very strong, one I do feel strong. And then they also have pain, it makes sense. Paresthesia, pins and needles sensation, because less blood flow is going to the nerves of the legs and of the feet. So they feel, eventually they're not going to feel anything. But when you have this transition of feeling something and not feeling something, they get these things we call, and I'm sure you've had these before, pins and needles. I don't want you to think you have PAD, but it's probably you're studying and you're putting your arm on the bed over here and you're studying, and all of a sudden you're getting pins and needles on your hand over here. That's because you're pressing on a blood vessel over here. You pick up your arm and it goes away. So that's why you get that. Paralysis, you get weakness, again, less blood flow going to those muscles. Okay, and you also get polar, or something called I can't even pronounce this. Poikilothermia. We used to say polar. But this is just a cooler area. Less warm blood going to your legs means that the skin of those areas are going to be cooler than the other leg. So always when you do these things, pulses and seeing pins and needles, weakness, always check the 2 legs at the same time, or at least compare it. Don't just do one leg. You got to look at the other leg to see what a normal thing is for that particular person in. Does that make sense? All right. The skin also tends to be dry, shiny, and decreased hair. Why would you have decreased hair? Why? Less blood flow going to the hair follicles, so the hair won't grow, and that's what happens. Okay. So that's what's happening with that, all right? And less blood going to the skin itself makes it look dry and shiny, all right? Less blood flow going there. So that's why they get. That's like I said, I look at people. If they're wearing shorts, they're older folks, I can see what's going on, all right? All right? So skin is pinkish when standing up, but will become pale when lying flat, okay? I mean, skin is pinkish because what happens is when you're standing up, all the blood flows down there. Now, I know it's ischemia and stuff, but still, there's a lot of pressure. The blood is going to go down that area as opposed to up here. But then when you lie flat, now the blood is going to stay up here, and it's not going to be perfusing the legs in an efficient way. So now the skin appears very pale when you're lying down, but pinkish when you're standing up. Does that make sense? That's key to understand why it appears paler, right? All right? So, like I said, it's pale when elevated, pale when you're lying down, when it's elevated, not standing up like this, okay? And when you have less blood flow going to certain parts of the feet, that obviously will lead to necrosis, i.e. gangrene, right? So that's what happens. All right? All right, Raynaud's phenomenon. This is a neat phenomenon, not so much for the patient, but when you see the pictures of it, you'll see what I'm talking about. It's idiopathic in about 80% of people, okay? So meaning like we don't have a reason for it. What happens here is that they have this intense recurrent vasospasms of the small arteries. It usually affects, the most common site is going to be the fingers. We do see it sometimes in the toes, but mostly in the fingers. And they have a spasm, so less blood flow goes to those fingers. It's precipitated by chilling the area. So what happens is they're washing their hands in cold water, and all of a sudden they start getting pain, and there's certain color differences that happens at the fingers. Okay, they turn blue. Okay, so they don't want to go into winter areas. Okay? It's usually a benign condition. Again, we don't know the reason for it. The best thing to do is to avoid cold areas. All right, so you know, or wear a lot of thick clothes, especially on the hands. That's the best way to do this. Or just move to another place like Florida or the Caribbean or something like that. All right? It may be, however, and this is where we need to see this, it may be the first sign of underlying causes. People with lupus may have this. People with scleroderma. I know I didn't talk much about scleroderma, but in your other courses you may get into that. But what I'm trying to emphasize is that 80% of cases, it's usually benign, but we got to rule out other things. If everything is okay, then they fall into category 80%, and just tell them wear a lot of, thick gloves, try not to go outside in the cold, don't handle ice, that kind of thing, or just like I said, move to a warmer climate. Okay, and this is what happens. All right, is that their color, because of the spasm, makes it go. If it's cold, it'll make the fingers turn blue. And then when you leave, because there's less oxygen, that's the reason why. It's not because it is because it's cold, but it's just because there's less blood going to the fingers. You have this spasm that happens. And then when you get back to a warmer spot, your fingers just return to normal. Okay? And this is what the hands kind of look like. It's kind of a weird phenomenon. I've seen a couple cases of this, but we call it Raynaud's phenomenon, where it turns to, it's a phenomenon, meaning that in most cases we don't know the reason for it. It just happens. Okay? So that's what happens with that. Okay? Then we have Buerger's disease. Okay? Buerger's disease is inflammation of small to medium arteries, and what happens is there's thrombosis that develops, and it soon will occlude those blood vessels. Okay? Most common sites are the radial and tibial arteries, which means there's less blood flow going to the hands. It's almost exclusive to young people, 20 to 40 years old, and smokers. Smokers get this, okay? Not all smokers, obviously, but again, their fingers can turn blue. It can look like Raynaud's phenomenon, okay? But we see it classically in a 20 to 40-year-old, and they are smokers. If they're not smokers, they don't get this, okay? They get painful fingers and toes, intermittent claudication. If it does happen to the legs, they can get cold insensitivity, which looks like a Raynaud's phenomenon. It'll turn blue, okay? Complications is that if this is extended amount of time, it can cause ulcers, less blood flow going to the skin, creates these cavities, these ulcers, can lead to gangrene, and you might have to cut off certain things, all right, amputate. So the treatment for this is, the most important thing is to stop smoking immediately. Don't even taper off. Just stop it, okay? They get a very fast improvement with that, all right? If you have to, like I said, amputation if necessary, if it's gangrene, right? You've got to stop anything that's going to cause osteomyelitis. So the stopping of smoking is the #1 best treatment for this, okay? And you get a very fast improvement, usually within a week, okay? Okay, so venous disorders, and then we'll be done with this, all right? So venous disorders. Varicose veins, really quick about this one. Should have been talked about in A&P2. Sometimes they're referred to as varicosities or varices, same thing. So varicose veins, the opposite of varicose veins. Varicose veins. So most common site is the superficial veins of the legs, okay? What happens here is that there's an increase of venous pressure from someplace above, right? So that's going to be a backup of blood. And remember, veins have valves, right? When you have these valves, if there's too much pressure, and valves, remember, we don't, let's go backwards a little. In A&P2, we learned that the lowest amount of blood pressure in all your blood vessels is going to be your veins, right? The arteries, the blood just left the heart. So the greatest momentum of all that blood is coming right from the heart. So the arteries is the one that's going to be taking in on all the blood pressure, okay? By the time it gets to the veins, which is nearly the end of the road, well, the momentum of the blood, the pressure itself has decreased. So we have blood vessels, we have blood down by our legs that need to come back up to the heart to create venous return, right? So we need to make sure that the blood is not going to stay there. So we've got a few mechanisms to do that, right? We've got to move our legs a little bit. As we do that, the muscles in our legs will help milk the blood forward, upwards, all right? But we also have valves that are in our veins, mostly in our legs, right? The leg veins. That's going to make sure when the blood goes up there that it doesn't go back down. Keep in mind what valves do. Valves ensure one-way blood flow, right? So if this is going to be your valve, right, in a vein, so it goes like this, it opens, but then it closes. So now the blood that just went from your feet to, let's say, your thigh, it opens, lets the blood go this way, but now the valve closed. Now the blood can't go backwards, right? So because of that, another bolus of blood will go back up. So the valve is making sure the blood goes only one way. So we have that. So there's valves in our veins. So what happens here is that let's go back there. So if there's too much blood, okay, there's too much pressure, whether you're pregnant or you have some kind of liver disease, there's too much pressure in the blood that's upstream up here. That's going to put more pressure this way, is it not? So what's going to happen is this valve is not going to hold all that blood, and it disrupts, right? And when it disrupts, it'll widen because now you got more blood that's sitting here. So now it's going to widen like this, and now blood is not going to be able to go one way. It may sit there for a longer time and make the blood vessel, the veins themselves, be distended and tortuous. And I'll show you what that looks like. So when you have this increased venous pressure, you have this impaired valves in the veins, okay? means that you're going to have backflow of blood and you're going to decrease the venous return. If your blood is going to stay more down by your feet, that's less blood going to your heart, i.e. less venous return, a decrease in venous return. The veins themselves become very tortuous, twisted and turning. I'll show you what that looks like, just because there's so much blood that's sitting in there. Okay? So the symptoms of the varicose veins, and you got to contrast them to the 6 P's. So you should know, if you look at someone's leg, is it because of the symptoms or the signs that you see there, is it because of an arterial reason, or is it because of a venous reason? Does that make sense? So you should compare the 6 P's in the PAD, right, peripheral arterial disease, and what varicose veins are. They get itchiness, achiness, cramping in the legs, just because the blood is sitting there for such a long time. Edema is usually present, right? Because if blood is being in your veins, it's going to back up into capillaries. Blood is going to be shifted. Fluid is going to shift from your blood volume into an interstitial area and create edema. The skin tends to be thick and brownish in color. Pulses are present. There's no problem with the blood going arterial-wise. Remember, you don't feel pulses on veins. You feel pulses on arteries. So the pulses should be there in both legs. Okay? The skin temperature is normal because the blood is getting to those points. Right? There's nothing wrong with the arteries. The warm blood in the arteries are bringing it to the legs. All right? There's poor healing due to edema because the edema is getting really thick there. So that causes a decrease of arterial blood flow to the area. So it's kind of like, varicose veins can eventually lead to arterial complications too. Does that make sense? Because it's all one unit. The blood is, if there's a backup at one point, it's eventually going to be backed up with the arterial areas. And that's what's happening over there. Okay? So you should be able to compare those two. So again, your blood vessels, or your veins, here's the valve. So normally blood can go up and the blood can't move down because the valve is there. So it ensures one-way blood flow. But when you have a pressure that's greater upstream, then that could disrupt the valves over here and blood can go back this way and you're going to have distended veins. Sometimes the distended veins over here become tortuous because there's so much blood in there. And these are some examples of varicose veins. You've probably seen similar situations, but you'll see how it looks tortuous like that, and it's twisted and turning. Some of them might be very small, but you can't actually see the veins themselves. You can just see where the blue colors are. And I want you to keep in mind, too, that we've always been talking about varicose veins in the legs. That's more common, but I need you to also understand, because we're going to get into that with the digestive system, that you may get it also in the abdomen and the chest. It depends on where the venous pressure is increased and where the backup would be. If it's going to be someplace in the liver, then you're going to see a lot more varicose veins in the abdomen, as you see at the one over here. But if you have a lot more pressure in the pelvic cavity, like in pregnancy, then the backflow will happen more in the legs. Does that make sense? Now, don't get me wrong, that if you have a backup of blood from the liver, you're going to get the varicosities in the chest and in the abdomen. Eventually, if it's long-standing, it will go down to your legs also. All right? But when you see it in the abdomen, you know that there's something wrong, most likely with the liver. Okay? Phlebitis. All right? This is inflammation of the vein, usually due to some sort of infection. Basically, the vein itself it's thickened and it can obstruct blood flow. The most common site, again, is going to be the legs. Okay? So you have this vein, the wall of the vein gets inflamed, so it gets thicker and thicker and thicker. That's going to press against the, here. If you have, let's say, a vein that normally is like this, but now the wall of the vein is going to be thicker, inflamed. I'm exaggerating this so you can see it. So now you're going to decrease the lumen up here. So that's going to obstruct some blood. Normally, if you have a bolus of blood, can normally go up there. Now it's going to have be funneled. It's going basically you know, if you're driving, going from 4 lanes, now you're only going to 1 lane, right? You're still getting blood up there, but it's being obstructed somewhat. And we see it most common in the legs itself, okay? Usually most people, it's asymptomatic, but it can be painful. A lot of times you'll see a red line on the skin following the course of the vein, okay? And you'll see where that goes, all right? Then we have thrombophlebitis, which is basically inflammation, but it's due to a blood clot. So you can have a thrombus there, and one of the complications, as you know, can cause an embolus. But the other thing it can cause is phlebitis, where the area there just gets inflamed, and that can also cause, like you just saw over here, an obstruction with the blood flow. So, but keep in mind, deep vein thrombosis occurs, and that can also lead to, as you know, the embolus, all right, going to the lung, all right? All right, so that's all that. Now, this kind of makes somewhat fun, right? I don't do drugs, right? It's an older folk, like an elder guy. I get the same effect by just standing up fast, right? Again, orthostatic hypotension.